Our next presenter is Paige Willis. She comes to us from Baylor in Plano, Texas. She has a specific interest in teaching the future of our profession, our perfusion students, both didactically and in the clinical arena, which that takes a special kind of person. So I really appreciate her dedication to that. Today, she's going to be teaching us a little bit about the effect of de-airing during cardiac surgery.
Good morning, everybody. Thank you for your attention this morning. Today I'm going to present on effective de-airing during cardiac surgery to minimize patient risk, the Baylor Heart Plano experience. Baylor Scott & White, the Heart Hospital Plano, is one of the top 5 busiest cardiac surgery programs in the United States. We have 9 cardiothoracic surgeons and 10 operating rooms, and we get through an insane amount of cases some days. Those include anything from cabbages to single and multi-valve procedures, combined cab valves, Ross procedures. We have one of those going on today, apparently, and both aortic aneurysm and dissection repairs. All of that has led us to be awarded 3 stars in all 5 STS categories this year, so we're pretty excited about it. Before we get all the way started, I just have a question for you guys. How many of you are using CO2 field flooding for de-airing your hearts? Quite a lot of us. Okay, excellent. And then how many people are only using patient positioning and like cardiac manipulation for de-airing? Like no CO2 involved. Got a couple? Awesome. Should be fun then. Like I said, my name is Paige Willis. I'm a perfusionist at the Heart Hospital Plano. I'm also the clinical coordinator and an instructor for the Heart Hospital's Cardiovascular Institute Cardiovascular Perfusion Program. And I have one disclosure of Artivion. I did an odd amount of research for this because I was thinking like CO2 field flooding, of course, everybody knows what that is. And then I kind of got into it and wanted to look at some of the history and found that, you know, it's kind of crazy. It goes all the way back to the 1950s. We're talking the very beginning of cardiac surgery here. Some of the earliest things I found were related to CO2 field flooding was the Meyerly paper, it's Meyerly et al. It was reported in the American Medical Association Arch Surgery Journal in June of 1957. That the research team in question injected 10 cc's of CO2 into the cardiac arteries of dogs back in 1954 and had no neurologic defects. So they suggested that the introduction of CO2 did not result in the same damage that you would have seen with the introduction of air. The authors also reported utilization of CO2 to flood the surgical field on several occasions. Given the characteristics of carbon dioxide and the results found, it was determined that, and I quote, the use of carbon dioxide atmosphere may become a feasible surgical technique as surgery of the left ventricle is developed. In the 1958 edition of Surgery, Nichols et al. Proposed displacement of air in the open heart or aorta by CO2. We move on to 1963, and we find Eguchi et al. Describing the adequate flow of CO2 for maximum air displacement. I know this is something that we all still talk about today. They concluded that 5 liters per minute provides that maximum displacement, and greater flows really didn't have any significant improvement. Some later studies looked into CO2 versus room air densities. And the CO2 was described there as 1.5 times more dense than air, accounting for that preferential filling of the surgical field by CO2. Webb et al. Described in the Annals of Thoracic Surgery in November of 1997 that CO2 field flooding maximized residual intracardiac air residual intracardiac air after open heart operations by up to 85%. It was concluded that this reduction in air was due to the relative density and solubility of CO2 as compared to room air. This is actually a really interesting study. They had an N of 78 patients, and it was shown that 22 patients were managed with careful de-airing procedures. And that's what we're talking about, like of patient manipulation and moving the heart. And they were shown to maintain a presence of air bubbles for at least 30 minutes and usually 45 minutes after cross-clamp removal. The 56 patients that received CO2 field flooding, 34 of those had no foaming observed at the time of onset of cardiac contractions. In an additional 14 cases, all bubbles were gone within 1 minute. And in the remaining 8, the bubbles persisted for 1 to 24 minutes following resumption of cardiac activity. So from the early 2000s kind of to the present, it seems like the main debate has shifted from whether or not CO2 field flooding is advantageous to that of which delivery device of CO2 would be more so. An independent study carried out by Vandenberg et al. In 2020 sought to answer that very question. They had 6 CO2 application devices, 3 commercial and 3 improvised, and those were tested against one another at various flow rates to determine that answer. This team reported in the Journal of Thoracic and Cardiovascular Surgery in March of that year that the commercially available diffusers generally created less turbulent flow than those improvised, and of the commercially available diffusers, the Carbonate device was superior to the other tested diffusers. Here's a visualization of the relative turbulence of flow produced by those various CO2 delivery devices tested in that Vandenberg experiment. These are going to be at 4 liters per minute. On the top row, from left to right, we're looking at the Carbonate, the Carbon Mini, and the T-Med. And then across the bottom, we've got a multi-perforated drainage tube, so basically a chest tube, a 1/8 inch PVC tube, and a 1/8 inch PVC tube that was tipped with 3 layers of gauze. So here you'll be able to see what that flow actually looked like in their experiment. This is going to be at 4 liters per minute. It's nice here because usually we don't really get to see anything. We're like, oh yeah, the CO2 is on. Sure, looks great. But this experiment was really cool, I thought, because it gave us a little bit more visualization of that. The Carbonate and Carbon Mini carbon dioxide diffuser systems. So these were developed by a CV anesthesiologist, and they've been available in the United States since the early 2000s, but available in Europe earlier than that. Use of one or the other, so if you're looking at Carbonate versus Carbon Mini, is going to be dependent and contingent upon the length of the incision. The Carbonate is generally used in the adults. That's going to be the gray tube. It's usually in the adults and full sternotomy incisions, whereas the Carbon Mini, which only has a max flow of 8 liters per minute, is going to be reserved for pediatric and minimally invasive procedures. Both of these are available at our facility and are considered standard of care by our surgeons. They're on everybody's preference cards, and if they don't get pulled, we'd all have to hear about it. As far as the reduction of turbulence of flow, as demonstrated by that Vandenberg experiment video on the previous slide, less turbulent flow equals more carbon dioxide in the thoracic cavity, allowing for this barrier that you see in the illustration. The formation and maintenance of that barrier is key to effective CO2 field flooding and the prevention of that blood-air interface. A randomized controlled trial published in Circulation in 2004 looked at the effectiveness of this device to reduce the time for microemboli to disappear. With an N of 20 patients evenly divided between a CO2 diffuser and a control group, the authors monitored microemboli via TEE from the time of cross-clamp removal to 20 minutes post-bypass. The median number of microemboli seen during the study period was 161 in the carbon dioxide group and 723 in the control group. Following termination of bypass, the median time it took for microemboli to reach zero was 7 minutes for the CO2 group and 19 minutes for that control group. As far as the bacteriostatic atmosphere, we have kind of an interesting story about that. One of our founding surgeons, Dr. William Ryan, originally started using the carbonated device while he was working at Dallas Presbyterian Hospital. The decision was made in large part because of this bacteriostatic effect. At the time, there was a lot of construction going on in the hospital, and they saw their surgical site infection rates start to rise. After the introduction of the carbonated system, they saw those infection rates decrease along with decreasing their de-airing times. So when Dr. Ryan came over and started our program at Baylor Heart in 2007, he brought the device with him, and we have been using it ever since. I thought it was really interesting looking into all of this because when I was first approached with it, I was like, okay, a CO2 line, that's great. Sounds very interesting. And the more I dove into it, I was like, I'll never just look at this as just a gray CO2 line anymore. Like the amount of research and development that went into it and the actual science behind it is pretty interesting to me. So I know a lot of people don't buy into the CO2 thing. I hear it all the time. They're like, you don't even know if it's in there. You know, you can't see it. It's a clear gas, right? So thanks to infrared technology, now we can see it. This is really going to be the best visualization of that. Okay. As far as the Baylor numbers on this, I pulled some information from our 2023 patient population. We did a total of 2,027 cases in 2023. And as I previously mentioned, the Carbonate and Carbonate Mini, or Carbonate and Carbon Mini are standard of care in our facility. So any open heart procedure that was done in this data set would have been utilized. I made a selection of 155 cases, which is about 8% of our total. And I'm sure some of you are wondering why 155, where did those come from? So I did it for two main reasons. The first of those is that these are the cases that I pumped in 2023, so it was really easy to get the data for them. And honestly, I have a lot of stuff going on, so I needed something that was going to make that a little bit easier for me. And the second reason is that there was built-in randomization of our overall caseload just because of our daily rotating schedule. I don't get to decide which cases I do. It just comes up for each of us as we go through. So of that 155, 105 were male, 50 female, and the age range was 21 to 85 years. I did exclude some procedures. There were 38 cabbage procedures that were removed because there was no use of CO2 field flooding on those procedures. I removed 7 cases where no cross clamp was used and 9 cases where we had multiple runs, either multiple bypass run or multiple cross clamp applications. And then 8 cases where it was necessary to remain on bypass after cross clamp removal due to the need for an additional support device to be placed. So we ended up with a total of 93 cases that were analyzed. So this graph shows the time between cross clamp removal and bypass termination for those 93 cases that we're looking at. I chose this data point because it gives us a general indication of the time it would have taken for de-airing. It's not an exact science, but all of this is retrospective, so I was working with what I had. We had 38 patients that took between 2 and 19 minutes. We had 21 in the 20 to 35 minute category, 10 in the 37 to 50 minute category, and 3 in the 54 to 59 minute category. Then we had one patient each at 75 minutes, 88 minutes, 90 minutes, and 119 minutes. But it should be noted that those 4 highest times were patients that were receiving either a total arch replacement with an elephant trunk or got a tricuspid valve repair that was completed after the cross clamp was removed. So thereby that significantly is going to extend that time. So of the 93 patients, 59 of them, or 63%, had a de-airing time of less than 35 minutes. In conclusion, and this has actually been talked about a couple of times today, it's pretty well established that increased time on bypass increases patient risk for morbidity and mortality. As recently as March of this year, Boccanelli et al. Looked at bypass times as related to postoperative myocardial injury in mitral valve patients and upheld that belief. The use of the carbonate flooding with use of carbon dioxide flooding with a carbonate diffuser can decrease that de-airing time. We've had multiple studies referenced today, along with the Baylor-Plano statistics that I've shared, that agree that the use of CO2 flooding with the carbonate diffuser can decrease that de-airing time. Therefore, I would conclude that the use of the carbonate and carbon mini diffuser systems may result in decreased patient risk. These are my references for today. I just want to thank you all for listening.
Thank you, Paige. Great job. We've got time for a few questions. I'll start off with one. You said that, I think I heard you say that the Carbon Mini has what was the maximum flow rate?
8 liters a minute.
8 liters a minute?
Yes.
And the recommended flow rate for flushing is 4 liters a minute? Is
that the recommended from the reference material that I found from the literature search said 5 liters a minute. We tend to run ours at 6. I just don't think there's really a definite answer on that. I know that, like, I have seen it run as high as 10 very consistently, and that seems to be unnecessary and really just creates more problems for us on pump as far as CO2 control.
So we have one of our surgeons primarily that'll flush, and he uses the gauze over the tip of a piece of tubing. My question was around that, because if we were going to move to something like this, we do primarily pediatrics, but about 50% of our patients are adults, larger patients. So being able to just use one of those devices across all the patients versus stocking both would be interesting. So would you say that we could get away with that, with the 5 liter recommendation, max 8 liters on the mini, just using the mini across all those patients? Or what?
I think that the problem that comes apart at that point with the mini is the size of the incision. If you're talking adults with like a full sternotomy, it's more about the capacity to fill with the smaller tip on there. Okay. I think you'd probably get away with it easier in the other direction if you just ran it at a lower flow, but don't quote me on that.
Got it. Thank you.
Hi there. Thanks for the good talk. I'm interested in, with the varying flow rates, how do you guys monitor CO2 during the case? I think you were just alluding to that, but CO2 concentration in like closed chest cases versus open and everything else. Do you see your CO2 rise significantly unknowingly, or do you have like a CDI or something like that?
We do run CDI on all of our cases, so it's pretty easy to keep track of. It's not hasn't really been a big difficulty. It's really just a matter of, like, you see it start to rise. Also, most of us at this point, it's going to go up as soon as you turn the field flooding on. So you can kind of compensate for that with your sweep gas.
That was a great talk, Paige. I'm curious about how high and how much compensation you have to do. Again, I'm in the peds world too, and we just we drop a feeding tube in, maybe very ineffectively. But we oftentimes can't run it any higher than a half a liter because we can't compensate with a high enough flow based on what our flow rates are per oxygenator. So I'm curious, if you're flooding the field at 5 or 6 liters or even up to 10, what do your sweeps look like?
I don't do anything with pediatrics. We're all an all adult practice, so it could be a little bit different from that standpoint, but we usually don't see an increase of more than 1 to 2 liters in the what you're running your sweep at to begin with. I think generally speaking, the highest I see running 6 liters a minute of CO2 into the field would be a sweep of about 5 liters.
Yeah, because that makes me wonder, like, am I just absorbing all of it in through my pump suckers versus like,
Right.
getting into the field? So it was really
Right. And that could be
interesting.
part of the issue with that turbulent flow is it's
Right.
kicking it back out and it's kicking it straight to your suckers.
Right. Your visuals were really helpful with that. Yeah,
Thank
thanks.
you.
I have a couple online questions. We have Sandra Mohammed asking, what do you suggest if we don't have the Carbonate CO2 sprayer available?
I mean, I think that CO2 flooding, regardless, is kind of the way to go. That's one of the things that they were looking at in that Vandenberg experiment of what is the best way, like the most effective way to deliver that CO2. And I mean, I think if the answer is have the commercial diffuser or have no CO2 at all, I would still say run some CO2.
The next question we have is from Cartel Cross asking, any considerations for running the root vent once the cross clamp's off?
I'm not sure if I understand the question, but we do run our root vent once the cross clamp comes off, yes.
The next question we have is from Rebecca Jones asking, how are de-airing times measured and cross clamp off until root vent removed?
Well, like I said, all of this was retrospective. So really all of the information that I had as far as times at that point was our cross clamp off and our bypass off. So that was really what I was working with at this point. I think it would be an interesting thing to look at as a future study of actually measuring that time to see when the root vent does come out. But that would be more of a prospective study.
Gotcha. The next question we have is from Callie Towner asking, have you had issues with keeping up with the patient's CO2 parameters with sweep for patients where CO2 flooding was used?
No, that was one of the questions that was from over here too. I'm not usually seeing anything over about 5 liters a minute. And if we do have any issues where we're seeing our CO2 increase at like a greater rate, then you can always turn it down some, turn down your CO2 flush.
Sounds good. Thank you so much.
I'm Bob Hayes from Sacramento, California. I'm wondering if any of your surgeons come off pump and leave aortic root vent on and give and get, give what you get back and still the air after coming off bypass.
Every now and then with some of our more extensive, especially at the aortic surgeries, we will do that, yes.
Hi, hello. I'm Kiara King from Houston Methodist. So I was wondering, in regards to CO2, do you believe flushing the circuit prior to priming with CO2 will help in eliminating air embolism?
I don't know if it helps with air embolisms, but it definitely helps with de-airing your circuit when you prime. We actually had a conversation at my facility about this last week because we were discussing the days when we had external arterial line filters and how if you did not CO2 flush it, it would take you, easily twice the amount of time to get the air out of that circuit than it would if you ran some CO2 through it. So I think it can be beneficial. And I know a lot of places do that pretty routinely.
Thank you.